Okay, so you should see my slides now. I'm a pharmacist at WGH. With my colleague, General Surgeon Dr. Alex Poole, I developed the Yukon Frostbite protocol. Last year, we actually celebrated our 10-year anniversary of our protocol. And the last decade, really, frostbite became a bit of a passion for me. Like I've learned pretty much everything there is to know about frostbite. And I'm glad I can talk to you guys today because I think nurses in community health centers are in a prime position to recognize frostbite and treat. So I'll hope my talk is of interest to you guys. So it all started back in 2014. Dr. Poole treated 3 patients with severe frostbite and called pharmacy. Excuse me, sorry.
I'm just checking through.
Okay. So treated 3 patients with severe frostbite and called pharmacy to see if we had a medication called Iloprost. And what we realized is we didn't have that medication and realized that we didn't have much to offer to frostbite patients back then. And unfortunately, we pretty much waited and amputated. So we started to do a lot of research on the topic and drafted a protocol to better treat frostbite patients. We based our protocol on the evidence available in the literature. So it starts with rapid rewarming of the extremities and then grading of severity on a scale of 1 to 4 from mild frostbite to severe frostbite. And treatment includes aloe vera, ibuprofen, as well as iloprost, tenecteplase, and enoxaparin. So I'll go over all the steps of the protocol today. We saw the need to develop a frostbite protocol because frostbite remains a rare condition. It's relatively rare. Like there's a study in the States showing that it's less than 1 per 100,000 person. It affects individuals with social disadvantage, homelessness, substance use disorder, alcohol use disorder, psychiatric illness, military personnel, but also like outdoor adventurers and workers in cold climate. And of course, there are higher rates in rural northern climates during the winter and at temperatures between -20 to -50 degrees Celsius. Just at WGH, we treat in average 5 to 15 patients with severe frostbite per year. Just to start with a few definitions or clarified terms, frostbite is a cold injury caused by freezing of the tissue, so literally freezing of the parts of the body. Frostnip is also cold induced, but it's a vasoconstriction of the skin with ice crystals only forming at the surface of the skin. So there is no ice in the tissue, and usually it resolves without permanent tissue damage. Immersion foot or trench foot is a non-freezing cold injury from prolonged exposure of the feet to damp and cold conditions. And pernio is also a non-freezing cold injury from acute or repetitive exposure to cold, and it causes or it creates red or purple nodular, painful or pruritic lesions. I'm just going to put Raynaud up there because it's not a cold injury per se, but it is exaggerated vascular response to cold or emotional stress. And it's usually looks like sharply demarcated color changes of the skin in the digits. So the normal skin temperature is about 32 degrees Celsius. And as the temperature in the environment drops and the limbs become cold, we start feeling cold sensation at 28 degrees. When the skin reaches about 20 degrees Celsius is when we start feeling pain. And when the skin temperature reaches 10 degrees, that's when usually it becomes numb. And that's the last kind of warning sign before frostbite. So frostbite happens when the tissue or the skin, the tissue drops below 0 degrees Celsius. Actually, the freezing temperature of the skin is a little bit below 0 because of the electrolyte content of the cells and the extracellular fluid. So it's about -2, -4 is the actual frostbite temperature, or skin, I should say, tissue temperature. So before rewarming, frostbite don't look like much. Like the signs and symptoms are not very obvious. Patients don't have any sensation, and the skin is white or grayish yellow, hard or waxy to the touch. And I just want to do a quick review of the pathophysiology just to understand better the treatment later. So when we are exposed to cold temperature, initially there's the Hunter response where there's a vasodilation happening, but as the temperature drops, that vasodilation is replaced by vasoconstriction. And then when the tissue freezes, there's literally ice crystals forming in the extracellular space. And in an attempt to reestablish the osmosis, like the cells get dehydrated, and there's endothelial cell disruption and an influx of like red blood cells, platelet aggregation, et cetera, et cetera. When the tissue thaws is when a lot of the injury to the tissue occurs. So the ice crystal, as we're thawing, the ice crystals melt, and then it leads to interstitial edema. We see an increased endothelium permeability, increased thrombosis, free radical generation, and an influx of really bad prostaglandin and thromboxane, which cause vasoconstriction. And it's that vasoconstriction, like in the extremities, that decrease the oxygen to the tissue and eventually lead to necrosis or ischemia and necrosis. So that's why frostbite carry a risk of amputation. The way we rewarm frostbite matters. In the 1800s, during the Napoleon War, their chief military surgeon was actually recommending or advising soldiers to rewarm frostbite in snow. And then the soldiers at night were rewarming the frostbite by the fire, and then the next day they were walking again in the cold, so refreezing their injuries. And what we've learned from that is like rewarming by the fire was causing secondary burns in addition to frostbite, and that repeated cycle of thaw and refrostbite was really bad and led to bad outcomes. In the 1930s, there were studies in animal in Russia, and they found that the best way to rewarm frostbite was in hot water. And then it was not until the 60s that a doctor in Alaska, Dr. Mills, studied rewarming in human patients or with frostbite. So what Dr. Mills in Alaska found is that he verified or found that rewarming frostbite with excessive heat or direct dry heat, or like spontaneously or passively rewarming frostbite was leading to worse outcomes. So Dr. Mills actually established again in humans that the best way to rewarm frostbite was in a bath in hot water, using either a whirlpool, a basin, or a laundry machine, which was kind of funny. So our protocol starts with rewarming, and how we do rewarming is by immersion in hot water of about 37 to 39 degrees with stanhexidine for 30 minutes until the skin is soft and pliable. And this is the first thing that you should do in health centers. You can use a bucket, a basin or bath, and use tap water. So you want to let the tap run for a few minutes until the water is hot. It should be hot, but not burning. And then before the patients put their hands or feet in the water, you should remove any jewelry or constricting clothing, sorry, because it will swell up after. And you want to also clean the wounds gently during the rewarming. At WGH, we have the luxury of having three portable whirlpool. So what we use, like there's a heating element that keeps the water hot, and there's a motor that actually swirls the water, so it offers like a gentle debridement of the wounds. And that's what we use for rewarming and hydrotherapy. It's very practical, but it's not essential. So if you don't have that, a basin, a bucket, or a bath will suffice. Okay, so the next step on the protocol after rewarming is assessing severity. So like I said, we are using a scale of grade 1 to 4, grade 1 being milder frostbite and grade 4 being more severe. A quick note to say that not having fancy imaging in health centers is not a barrier to grading severity. So X-ray has a very limited role in frostbite. Angiography is useful in hospitals where they do intra-arterial thrombolysis. Bone scan can be useful to predict the degree of amputation. But we don't have that either at WGH. We have used microangiography, which is a type of fluorescent microangiography, but we don't use that routinely. So I just said that imaging is not very accessible or useful to grade frostbite, so we rely on the work of Dr. Emmanuel Cauchy in Chamonix in France. So him and his team developed a visual grading of frostbite severity. So what they did is they visually assessed what they thought was the grade of frostbite, and then they did bone scan, and they followed up their patient, and then they basically correlated the amputation degree with their visual assessment. And they graded the severity of the lesion from its proximal extension from the tip to the center of the body. So basically, a grade 1 extends to the distal phalanx, a grade 2 to the middle phalanx, grade 3 proximal phalanx, and grade 4 the metacarpal or the forefoot of the feet. And Dr. Cauchy and his team correlated this with amputation risk. So grade 1 does not carry a risk of amputation, it's pretty much 0. Grade 2 and 3 frostbite carry a risk of amputation of about 40 to 80%. And grade 4 frostbite carry a risk of about pretty much 100% without treatment. These are great pictures from Nunavik in northern Quebec. These are pictures taken before rewarming, and I just wanted to show you that sometimes we actually see a line where the frostbite has progressed. So that was before rewarming, and that was after rewarming. The colors kind of switch, but we can still see that clear line where the frostbite has progressed to. I want to talk about blisters. Blisters will usually appear 6 hours after rewarming, up to 24 hours. They can either be clear or hemorrhagic. Clear blisters are a good sign, meaning that the injury is probably superficial. Hemorrhagic blisters usually imply or involve like deeper injury with rupture of the little micro vessels. We usually recommend to drain and debride only clear blisters, and especially the ones that interfere with movement when they're over joints and stuff. But we usually leave hemorrhagic blisters intact. These are pictures from one of our patients, and you can see how much the blister and the edema can be significant. The first picture is right after rewarming. The second picture is 24 hours after rewarming, 48 hours later, and then 3 days later. So really, really significant blisters and edema. This is another patient with also severe frostbite, immediately post rewarming on the first picture, and then evolvement over the next couple of days. Usually the blisters subside after 7 to 10 days. These are the pictures from Nunavik where you can see the evolution as well. Okay, so now we have rewarmed, we have assessed severity. Now we're going to talk about treatment. So what we do for grade 1 and all grades of frostbite is hydrotherapy daily, debridement and aspiration of clear blisters. We use aloe vera and non-sticky dressing, non-adhesive dressings. We use ibuprofen. We elevate affected parts. We recommend avoiding tobacco, like smoking, alcohol, and tetanus immunization. I'll speak right away about wound care. So there's not a lot of research on frostbite wound care per se. So we have to go back to the studies from Dr. Mills in Alaska in the 60s. So back then they studied like a group of subjects with and compared closed versus open method of wound care. And in the closed group, they actually used like ointments, occlusive dressings, wet dressing, even casts, and realized that the amputation, the group with the closed method was doing worse, and they're leading to more amputation, probably in part by increased risk of infection with that closed method. And the findings from those studies in the 60s is still what guides us with our wound care today. The feet and hands are essentially the same. So you want to ensure the wrapping, the dressing doesn't interfere with range of motion. In the case of a hand, the patient should be able to make a fist. You should dress each digit with a non-stick dressing, cover with gauze, and then wrap. In the case of the hand, wrap each finger with cling and secure with tube dressing. Okay. So I'm going to move into like the pharmacology and the treatment options. And to understand the medications that we use, I just have to go back to the arachidonic acid pathway. So there was a very interesting research from in the 80s from Chicago researchers. What they did is they actually aspirated the fluid from frostbite blisters and found that thromboxane and PGF2 alpha were increased or in high amount in blisters of frostbite, and they hypothesized that those bad thromboxane and prostaglandin were responsible for the vasoconstriction, the platelet aggregation in frostbite, leading to ischemia and necrosis. So that's why, and they also found that the good prostaglandins were actually low, and that's why they studied all those medications that we use now for frostbite. So NSAIDs and aloe vera, and I'll speak to that in a sec.
Josie Ann,
Yes.
just could you at the bottom of your screen it says stop sharing it. It's hiding some of the information that.
Let's see.
Oh,
Is that better?
okay. Thanks.
Great, thank you. Sorry about that. Okay, so those same researchers in Chicago actually found that the active substance in the aloe vera plant had good effect on frostbite. So actually, aloe vera is a thromboxane inhibitor, and it limits the production of bad prostaglandins involved in frostbite. It also has antimicrobial and anesthetic properties. It can improve wound healing and burns. So they did research in both animals and humans, and they they realized that aloe vera, when it was part of a protocol, helped with wound healing. We use in the States, they use a product called Dermade. We use a product called Aloex, which is the best product we could find of like aloe vera and in high concentration, and we use that on our frostbite wounds. I only recommend aloe vera, and the reason is like all the other products have not been studied in frostbite. So, and I also don't recommend using polysporin because frostbite are actually not infection prone. So I don't see the indication of the need to use polysporin. So I actually, if you don't have aloe vera, I actually suggest to leave it without any topical agent or open. So NSAIDs, like anti-inflammatory drugs, block the arachidonic acid pathway. So it's logical that they can be useful in frostbite. They were the first medications to be incorporated in frostbite protocols in the 80s. In the early studies, a decrease in amputation rate and length of hospital stay. And it's in the 80s that they popularized the use of ibuprofen, and some of the experts at the time suggested that ibuprofen was better than aspirin because it was targeting the bad thromboxane and prostaglandin while preserving the good prostaglandins, and that's what they hypothesized, and it has never been verified. So probably aspirin and ibuprofen are both good. We use ibuprofen just because that's what's been used for frostbite since the beginning, but we'll probably learn more, and perhaps we'll change that. But for now, that's what we're using. Okay. So now I'll move to our intravenous treatment. So maybe I should say that what's very important is if you identify frostbite of severity 2 to 4, it's very important to consult WGH because the IV treatment that are available here are only available here. So we use iloprost, thrombolytics, and heparin for treatment of grade 2, 3, and 4. So iloprost is a potent vasodilator and inhibits platelet aggregation. It also improves fibrinolysis and has cytoprotective properties. If we go back to the arachidonic acid pathway, prostaglandin PGI2 or prostacyclin is an endogenous substance in our body that is responsible for vasodilation and inhibition of platelet aggregation. And basically, iloprost is a synthetic analog of that prostacyclin. So that's what iloprost is. So Alex often says that if you had to retro-engineer a drug that would be good for frostbite, that would be it, because it does exactly what we want it to do. The problem that we encountered back in 2014 is iloprost was not commercialized in Canada. So it is still to this day only accessible in Canada through the Special Access Program. And it requires a lot of forms and paperwork, but we do obtain it ahead of time for future use under that Special Access Program. Back in 2023, we conducted a scoping review of all the studies that were done with iloprost for frostbite, and we gathered 20 studies that studied the use of iloprost for frostbite. And those studies included 254 patients treated with iloprost for frostbite. The first time it was used for frostbite was in the 1990s in Europe. A doctor in Austria used it to treat 5 patients with frostbite and had great outcomes. But it wasn't until 2011 that the first kind of landmark study was published on the treatment of frostbite. The Dr. Cauchy and his team in Chamonix, France, published the first and the only randomized controlled trial of treatment of frostbite. So basically, they had 47 patients and randomized them in 3 groups. One including iloprost alone, and another one iloprost plus RTPA or alteplase or thrombolytic. And they found that none of their patients with receiving iloprost had amputation, and only 3% in their iloprost plus alteplase group had amputation. So that really set things up for frostbite treatment. The thrombolytics are you're all familiar with. They're recombinant tissue plasminogen activator, or TPA or RTPA. So they initiate local fibrinolysis by binding to the fibrin within a clot and converting that plasminogen to plasmin. So that really addresses the thrombosis that happens in frostbite after rewarming. It was first studied in Minnesota and in also early 2000. And there's now about 15 publications on the use of thrombolytics for frostbite, totalizing about 300 patients. And in patients with reduced perfusion, it partially restores perfusion or reduces the amputation rate. What we know from the thrombolytic studies is we know that there are factors associated with treatment failures. The first one is delayed presentation, multiple freeze-thaw freeze cycles, and delay in initiating thrombolytics. And on that note, that's probably the most important factor that was verified in a great study from Minnesota. They found that the time between rewarming and initiation of thrombolytic had a significant impact on the risk of amputation, with each hour of delay leading to an additional 27% loss of tissue. So really, we know that thrombolytics work, but they only work if they're initiated within 4 to 12 hours after rewarming, and probably not effective beyond 24 hours after rewarming. And they proposed that new term, the warm ischemia time, and that's basically the time between rewarming and initiation of treatment. And that's what we're trying to minimize. It's that warm ischemia time. I consider frostbite now a little bit like a stroke or heart attack, where like time is tissue and each hour of delay worsens the outcome. So it's really important to treat fast, especially with thrombolytics. Until now, we were using alteplase, but we just updated our protocol to change the alteplase to the tenecteplase. Tenecteplase has a greater specificity to the fibrin. It leads to less depletion of fibrinogen, so in theory, less risk of bleeding. It has a longer half-life, and it's much easier to administer. Alteplase is a 6 hours infusion, whereas tenecteplase is an IV bolus over 5 seconds. So we also have moved away from using alteplase for other indications. So it just made sense to only carry one thrombolytic and use tenecteplase instead of alteplase. And just because fibrinolysis carries a risk of has a procoagulation effect, procoagulant effect, we always combine the thrombolytic with heparin, and we use enoxaparin for ease of administration. So back in 2016, after developing our protocol and treating our first patients, we published a case report of our 2 first patients using our protocol. And we published in a CMAJ, and then we started getting a lot of phone calls from all across the country. So it really sparked interest everywhere. 5 years later, we published a case series of our experience treating our frostbite patients for the first 5 years of our protocol. So we published that as well. We had 22 patients treated with our protocol. Of those 22, 5 also received alteplase. 77% were men, 39 years old in average. And what we noticed is we only had frostbite of grade 2 and more at -21 and colder. And interestingly, there was no correlation between the temperature and the severity of frostbite. Once it's frostbite, it's frostbite. And the duration of cold exposure ranged from 45 minutes to 60 hours. 45% of our patients in our first 5 years suffered frostbite from a sporting activity, a lot of them participating in the Yukon Arctic Ultra. And about 30% of our cases were related to substance use or alcohol. We did notice that there was a correlation between the use of alcohol or drug and the severity of frostbite, with more severe frostbite in that group of patients with alcohol or substance use. Our treatment protocol was well tolerated. Iloprost is usually the most common side effect is headache, followed by flushing and tachycardia. In the 5 patients that received alteplase and iloprost, 2 suffered from bleeding that required blood transfusion. So not treatment without risks, but otherwise fairly well tolerated. So we had, amongst our 22 patients, there were 142 digits affected. In our grade 2 and 3 patients, we had 0 amputation. And in our grade 4 patients, where the expected rate of amputation is about 100% without treatment, our amputation rate was only 50%. We also noticed that having a protocol and pre-printed orders really helped like streamline treatment and accelerate treatment and really reduce that warm ischemia time. So from the implementation of our protocol to 5 years later, we definitely decreased the mean time from presentation to treatment. So these are pictures from our patients. This first patient was treated with our protocol, but unfortunately suffered from had to have 9 out of 10 of his fingers amputated. So did receive iloprost and alteplase, but still had amputation. But this patient really had great outcomes, also grade 4 frostbite, but was able to avoid amputation entirely and did well. What's really interesting is in 2022, Calgary has adopted our protocol, and they actually published their experience using the same regimen, iloprost and alteplase, as us. And they also compared their numbers with historical control. And they found they treated 26 patients with iloprost and decreased their amputation rate by 50%. So not only did they reproduce our result, but they also, it was interesting because they also had a high proportion of their patients that were homeless, using drugs or alcohol. So quite vulnerable population, and still had great outcomes. And very recently in the winter, December 2024, Edmonton followed suit, and they're now using our protocol as well. And they are seeing a lot of frostbite in their emergency department and have treated like over 100 patients just in the last winter. So we'll see more data coming out of those big cities in Alberta. Last year, we published the first documented use of iloprost pre-hospitals, where we treated patients on board of a helicopter. We had actually already used iloprost before during ambulance transport from Mayo. So we are trying to move treatments to the pre-hospital setting to reduce that warm ischemia time and increase speed of treatment. Or yeah. And very proud to say that we probably influenced the states, because iloprost was not available in the US either. But in 2024, large part based on our work, the FDA has approved iloprost for use in frostbite in the state. So now it is commercially available in the US. However, it is very expensive, and the price tag is like $4,000 for a vial of iloprost. So it's still quite, to this date, still quite limited in the States because it's expensive. Yeah, so throughout the years, we developed a small team of surgeons, physicians, medical students, and residents, and we founded the Canadian Frostbite Care Network. We also got some grants and developed a fancy website. And our goal is really to promote collaboration, research, and education in frostbite care. And we're hoping to increase awareness to frostbite treatment, not only for the public, but also healthcare providers. So that's my last slide. What I would like to be your take-home message is to rewarm in hot water. You can assess visually the grade of severity. Consult WGH if you think the severity is of grade 2 or more, because time matters. With each hour of delay, amputation risk increases. You can use the aloe vera if you have some ibuprofen. Do some good monitoring of wounds and wound care. And if you have any questions, please call us or consult our website.
Thank you. I'm just going to stop the recording and then we'll move on to some questions.